Our facilitator is here, but got waylaid. Here he comes.
I do anyway, so.
All right. I'm Patrick Conway. I think we'll go ahead and get started. I was just joking that this will test my abilities as a facilitator, so I will do my best. So I'm Chief Medical Officer at Centers for Medicare and Medicaid Services and Deputy Administrator for Innovation and Quality. I am a pediatrician who does take care of children with complex healthcare needs, so a topic near and dear to my heart. And we have Chris Feudtner, Simon Hambidge, Rita Mangione-Smith, and myself. So we're going to have a series of discussions, and then we'll have some discussion with the panel, and then open it up to broader discussion. So without further ado, I'm going to turn it over to Chris. And you have bios in your packets if you want to read. This is an august panel, so if you want to read all their many accomplishments, they're listed in their bios.
Over the course of the next 25, 30 minutes, I want to essentially cone in on what I would conceive to be the main thesis of this talk, that we need to develop for that really 1%, 2% of the population who have what I think of as high-end, complex medical needs. We need to, in order to manage them, to take care of them, to improve their outcomes for them and their families, to develop the science of medical complexity. Now, for me, this journey began when I was a resident, and I was lucky enough to have Jeff Wright be my clinic mentor out in the University of Washington. And Jeff knew that I was very interested in children who had special needs. And he said, after we talked about what my well child care clinic would look like, it would be okay if I really focused right from the beginning on kids with complicated needs. So the first patient I saw was, I'll call him Dino. Dino was a refugee from Serbia. It was right at the time that we were having a major influx of refugees from that war-torn conflict area. And he was about 17 years of age with osteogenesis imperfecta. And as I was waiting nervously in the clinic for him to arrive, I saw the wheelchair coming around, and I saw the father pick up Dino. He was curled in a ball because his osteogenesis imperfecta had never been treated, and literally took a curled up individual and put him on the examination table. And that was my introduction to well child care. More than even that, as I looked at the young daughter that they had and I noticed her blue sclera, I realized that they had two people in the family with this illness. In the years that followed, I have had the pleasure, the honor of taking care of many children. Emma, a young girl who had a metabolic disorder, who got a bone marrow transplant and then had all of the, no other way to put it, terrible complications that can ensue from that procedure, and was so complicated that nobody in the community would take care of her with her seizure disorder, her graft versus host disease, her metabolic disease that was partially treated. Jaril, who was an adolescent who had Wegener's syndrome, and because of the kidney that had been removed and the mostly complete nephrectomy on the other side, had chronic renal insufficiency and very severe behavioral problems where he would pick at anything in his skin, including the port, and almost exsanguinated once before I got to take care of him because of that behavior. And the list just goes on. And in the years that led up to my career, when I started to do a master's in public health, this was the original idea that I had. of could I potentially figure out what it is that actually makes a complex patient complex. It's sort of like one of those things when we see a patient with complex needs, we all might agree, but we might all agree for different reasons. Now, for a variety of reasons, I was talked out of that particular project, which I sort of regret, but I can't argue with what subsequently happened. I got involved in, when I moved to CHOP, Integrative Care Service, palliative care. We've already heard a little bit of a shout out for that discipline. And I've been lucky to have many colleagues, Allison, Tammy, Jay Berry here in the audience, Jamie Feinstein, and particularly Thane Blinman, a surgeon who I work with at CHOP, where we've really started to think much more, if you will, in a hard-nosed manner and theoretical manner about what is it that we're talking about when we talk about complexity, and what would it take to study that in a more systematic, disciplined, methodical way. Why would we want a theory? I mean, I can imagine you sitting in the back of the room thinking, oh my gosh, you know, how airy-fairy. Well, I think it has a lot of practical implications. Firstly, I think it would help us to clarify many of the terms and concepts that we throw around and be able to speak a common language so we're not trying to build the Tower of Babel. By promoting that common language, we'd be able to talk about what are some of the phenomena going on for children that are making them more complicated. It would also allow us to have something to argue against. At the end of this talk, I'm happy if all of you disagree. I think it would be better to have an argument about what is right in what I say and what is wrong in what I say, because at least we'd be able to have a pointed argument. And we'd also be able to potentially move on and say, here's an area where we don't agree, maybe we should study that. Maybe this is an area ripe for investigation. In the end, I think it's a prerequisite or a foundational step in developing a science of medical complexity. And while you can find some papers that have touched on this in the medical literature, I would also say even in the adult world, I don't think that we have a developed science of what it means to be medically complex. We just tend to have a label. Now, my anxieties in doing this talk, or I don't want to come off as patronizing. I don't really know a whole lot about this. I don't want to be too abstract and ethereal, and I'm not sure that what I'm about to say is correct, but I'm going to put it out there because that's what I do, of just let's see whether if we sally forth and try to do this, where do we get? So the agenda is I'm going to start out with a few things to talk about, and then I'm going to move into complexity, medical complexity, problems, medical problems that are complicated, and some suggestions. These suggestions are really conjectures. They're things I've discovered in my own clinical practice as a provider of palliative care and complex care, but I can treat them as just ideas that need to be tested. Now, the starters. First, classification methods, which is actually what I was sort of assigned to talk about. And in negotiating with that, I said, let me broaden it a little bit. They're all tools for a job. Nothing drives me crazier when people look at, say, the complex chronic condition stuff that I did and say, we need to tweak. Of course you need to tweak it. You have a job that is going to be different in Massachusetts or Pennsylvania, and for a variety of reasons I'll go on to talk about, probably for any given project, you may want to identify children who are in or not in the group you want to study. It's a tool for a job. There will never be a system of classification that should work for everything. We know this. Let's just acknowledge it and figure out ways to make these tools work better in a quicker manner. Examples of these classification methods can be diagnostic-based, and there's a number of them. They can be functionally based, and they offer different pros and cons. And there are other ways, maybe even more innovative ways as we move forward, of looking at service use patterns or work that Jamie Feinstein has done in Colorado. Now, I'll just pause here. This is the number of medications the child is on, 1 all the way up to 10, and how many months they were on it over a 12-month period. My suspicion is, not knowing age, gender, diagnosis, any other thing, probably somewhere up here are kids we would like to bring into a plan to manage not just their polypharmacy, but the factors that are driving that polypharmacy. This is essentially a new way of thinking about how you might spot a population-level risk group. These risk stratification, I think we need to slow down. What risk are we talking about? The risk of blank needs to be spelled out. The blank may be mortality, During what time frame? Over the next 6 months, 6 years, how long? Readmission, when, what type, preventable, not preventable? Again, morbidity. And the big thing that I just want to say it out loud is I think a lot of risk stratification is actually cost stratification. And that is quite different than unmet medical needs, although they may be collinear, it's not complete, and it's a lot different than, say, a child who's actually suffering or getting subpar outcomes because of poor care being provided. Cost is not the same thing. And we need to, I think, as a community, come together and we can have very thoughtful conversations about the cost issues, but not confuse them or conflate them or just not spell out that that's not the same as outcomes that the families might value. That issue already came up when the discussion about care coordinators and care navigators. What's their allegiance, to the plan and saving cost or to the child and the family? So I've already said we need to be very clear about what we're doing here, otherwise we may obfuscate or be disingenuous. And I think a lot of the discussion about cost management in healthcare is disingenuous because we don't really want to say we're trying to save money. Now, I understand there are political ramifications of this, I get that, but we also need to have a level head as we move forward about how to be as honest about that as is humanly possible. And we also need to become a little bit clearer that risk is about a prediction in the future. Now, the reason I'm emphasizing that is a lot of the work that's been done to date on risk stratification is about cross-sectional data. And one of the things that we're finding is that children tend to migrate over time as to what their utilization pattern would be. So if on today we were to look at your profile of use or your diagnoses, what we need to know to bring you under care is what are you going to be potentially needing, what kind of medical problems will you be having, what will you be costing a year or two from now. And our models to do that are depressingly inaccurate for reasons I'll come back to. So last thing I'm going to say as a starter is this individual, and maybe missing a key part of this, is that I think a lot of complexity is driven not by patients, but by teams that are somewhat dysfunctional. Again, I'm sorry to say this out loud, but this is what I do. And that we need to start thinking about identifying teams that are not working well to figure out how to get better improvement out of them as opposed to just trying to identify individual patients. So what would that potentially look like? If we could develop a measure that would identify a group of patients that tend to be managed by a group of providers. They're sort of the latent variable behind this, or a group of clinicians. And we saw that that group of patients compared to similar groups of patients always had worse outcomes. We might be able to say that team in your location needs to go through sort of teamwork boot camp. So what would that look like? It would be something that we would be looking at variation across, say, hospitals. So this is a particular group of patients, I'm not going to get mired in the details, where they're basically going to need two teams to manage them. And you can see that some of the hospitals are going below the expected cost and others are above the expected cost in an adjusted model. Now, if you go through all of the permutations of teams that you have in your hospital, you could quickly come to realize, all right, I want to focus on the team interactions where I'm on the high end of the spectrum and sit down with those teams and say, why is it that I notice every time you guys are co-managing, your costs are much greater than similar type of co-management in another hospital? This is not about patients alone. As I often say, as a palliative care provider, I am part of the problem as the provider. And we need to own that and figure out how to manage that just as much as we have to figure out how to help the kids directly. So this ultra-high utilization, et cetera, even if we spotted them, even if I knew you were going to be an ultra-high utilizer or a very sick patient, what are we going to do now? Like, where in the conversation thus far have we had any discussion about me walking in to take care of Dino? What do I do to be the best doctor I could be, the best member of an interdisciplinary team, the best partner with that family to optimize his outcomes? If our interventions don't work, and here I'm thinking about palliative care where there are a lot of interventions that are sort of kitchen sink, the support trial, famous trial that was done in the 1990s that wound up having a null result. If you don't know exactly why you think something will work, Lord forbid it doesn't work, you're going to have a hard time moving on from that understanding where the system broke down in terms of the implementation of the trial and where you're going to go next. So that leads me to theory. Fasten your seatbelts here, I got to go quick. One thing you can say about complexity is it's complicated. People do not agree about it. And I say that it's a bit funny, but I also think it's a problem that we need to become mindful of and figure out how to solve, or at least pragmatically handle. We will never probably arrive at a consensus document that would last over time about what medical complexity is. But maybe we don't need to. We could think about different components that clearly are across any definition of complexity. They keep coming up. Components that interact, they have both positive and negative feedback loops. There's potential for synergistic success or cascading failure. Nonlinear relationships, which come up in all sorts of ways, both physiologically and in terms of outliers and payment and outcomes. Sets of relationships that are nested, and that repeatedly you need to think as a systems thinker. A phrase that often is stated, but nobody goes into the details of what that would look like. Now, all human beings are complex systems. So it can't be the case that the child is complex more so than any of us. They're not. What I actually think we're looking at is that it's because they have complicated problems. It's not that their physiology is more complex. It's that their physiology is not working in a particular way that creates a complicated problem. And those problems don't just, as I already said, emanate from the child. They also can emanate from the way that the team is working together or systems of care. So this is the argument. Medical complexity is actually about complex medical problems, and it's about more than just patients' pathophysiology. So problems and problem solving. This is what a problem is. I'm sitting here right now, and I have an ideal state. The question is, how do I get from where I am to where I want to be? That gap is the problem. And what makes problem solving difficult? I'm going to run through a few of these things. One thing is a lot of components. If you're juggling a lot of balls, it's harder to keep them all moving in the air. You might say that a patient with a lot of problems is simply complicated. I'm mixing up my words here. Complicated, not complex. If each of them is not interacting. As soon as they start to interact, you move from complicated to complexity. If it's simply complicated, you can do what a resident is taught to do, divide and conquer. I'm going to take care of that problem, I'm going to take care of that problem, and when I've done all 12 problems, I'll be done. Complex patients don't work that way, unfortunately. You have to be much cannier, and it's a more complicated skill set because the divide and conquer may not in any way, shape, or form be the most efficient algorithm. Because of the interactions amongst the components. Things that we see, that one problem is affecting the other. These problems are interacting. And the more that I throw at them, I start to get drug side effects, I start to get drug-drug interactions. This non-independence of the problems is part of what we are asking physicians to tackle. But I have to say, I've never been taught how to do it. I mean, I figured it out sort of on my own, but one big opportunity is to figure out how we train people to do this. And part of the there are going to be many parts of this. One additional part of the problem is that these interactions are often not linear. They often follow a power law distribution, meaning you're going to have a Pareto type of distribution, you're going to have the 80-20, you're going to have expectedly black swan events. So when we talk about risk management, 1 out of every 7, 8 years, I don't know how often, you're going to have an outlier in your population who is going to cost, oh my Lord, I didn't think a child could cost that much. And we're going to have real problems pricing risk capitated management because for the 6 years leading up to that 100-year flood, it's going to look like you're getting paid way too much, and then 1 year you're going to take a bath because you're going to get this huge outlier. And the law of large numbers does not work to protect you against that. So again, any of these ideas I could spend a lot of time talking about. I'll keep moving. What we don't know may in fact be the key missing part. And that one of the tricks that people can play as a way of laterally thinking is hypothesizing, what are we missing? This is figuring out that the parents actually have a mental health issue that they have not disclosed. Or this is figuring out that there is a problem that the family is not willing to talk about with transportation. or that there is another organ system that is not functioning as you would have expected. What would it take, hypothetically, to sort of figure this out? And there are tricks that we could be potentially investigating to figure out how you help people with diagnostic and problem solving. The certainty and uncertainty is a big issue, but not just that we don't know where things are going to land, but people handle this uncertainty so differently. If you go into an interdisciplinary team meeting with a variety of providers, so they can all be physicians, and there's uncertainty, you see in how they sit with that, some people get paralyzed, like we can't move forward until we've nailed down the diagnosis. I think, in fact, was said earlier, like wanting the diagnosis and the bag. I like the wanting the bag of. I often talk to parents, like even when we get the diagnosis, it may not tell us nearly what we would want to know about what's the right thing to do for your child. That the explicit way of how to manage that uncertainty is part of what a team needs to do to figure out how you manage complexity. The even bigger problem, though, is that in ethics consults that I field and palliative care, I walk into many situations where people don't even agree what the problem is that they're trying to solve. We need to figure out ways to define problems more clearly. The second is that people don't know what success will look like. Hey, I got a great idea, let's have a team meeting. Okay, at the end of this meeting, what's going to be different? Oh, I don't know, we'll have met. I'm not kidding. Like how many people go to meetings where or we'll talk about it and we'll decide on, if they even say we'll have made an action plan, but often we don't have a clear vision of what the world is what we want the world to look like after the next step. And we often have multiple objectives that we don't fully share with each other. Our vision of success differs. The solutions actually then become part of the complex system. This is one of the major problems, that we take a problem, we throw a drug at it, or we start a new intervention, and what have we done? We've given the family more work to do, we've added some drug effects, and we may actually be sort of trying to struggle in quicksand. Over time, these solutions tend to add up. So I typically will walk onto the wards and take care of children who have 12 plus medicines on their list. And I said, why is this the case? And, well, that's just all the well, can I start getting rid of No, you're not allowed to get rid of those medicines because somebody else ordered them. Really? These are some of the problems that if I think we were to be honest about what it takes to manage these more complicated patients, we need to have very systematic, structured ways of trying to simplify care back to the minimum that keeps the child stable, because the solutions are often part of the problem. This leads to the too many cooks in the kitchen. You don't want to try to solve one of these, care for one of these kids on your own. If you have many people involved, and I'm sure you've seen this as clinicians, one of the best things you can sometimes do is to say, who really needs to be on the really core team here? And everybody else is not invited to the meeting. And you do it politely and you explain the rationale, but we don't know what the optimal number of clinicians is going to be. What's the optimal amount of time? We have to manage that as well. Too much time doesn't work, too little time does not work. 10 minutes of time might work. Moving on. All of these problems are part of complex problems. Everything I've said up to this point would be true about solving any complicated problem, but medical problems add some additional things. One is that the problems are in the mind of the beholder. And I think this is another thing that's sort of a paradigm shift. A complicated child is as complicated in problem solving as we are limited to envision the solution. There are some people who can walk in, they may be the subspecialist, who will look at a situation and say, I know exactly what that is. I know how to fix that. More often, though, what we need are interdisciplinary teams. And I can tell you that I don't think that we get the full value out of interprofessional teams. We're just learning about interprofessional education, but we don't have projects that have worked through how do you calibrate that team? How do you get the orchestra to play to its maximum potential across the full range, from the cellos all the way to the violins and all of the percussion in the back? We know physicians talk way too much, that many of the allied health professionals talk too little. And I fear that the sum of the parts is greater than the sum of the parts, that the whole is less. And we should be able to figure out in really good teams, the whole is greater than the parts. We also often are dealing with problems that have a hierarchical focus of this driving that, this depending on that. I'm going to come back to this in a minute about leverage points and how you have to potentially think of that. That problems can be nested in other problems, a very core part of complex problems, but one of the big issues we see repeatedly is where social determinants of health, a phrase that I both embrace as a former historian of medicine and sociology person, but I think we need to be very specific. It's not having a car. It's not having money for rent. It's not having money for food. You know, if Richard III could lament that he needed a horse, let me tell you, there are many parents who would say, if I only had a car, I'd be able to adhere to this follow-up plan. And we need to figure out, and that was part of what was going on earlier today, the necessity of non-medical problems as the leverage point. If you don't fix that, you're not going to be able to win this battle. And that the family and the medical team are a key part of this. And I'm not trying to say that they're the cause of it, but they're part of the system, so they're part of it. And as being part of it, we need to figure out how they adapt and cope. Some families do so in ways that I'm just awed at, and other families you clearly see struggling. And yet the techniques that we have of supporting families, I think, could be way improved. And I see this on the palliative care side, I see it in the complex care. How can we build resilience and the abilities to basically do the things of cope, adapt, problem solve, like problem solving? How could these interventions be developed and implemented? Now, to finish this up, I know I'm racing here, but that's the task of just put this out there. We're asking too much of care coordination. Care coordination can do a lot, but I see a lot of patients who are going to need more than that. So I don't want to diminish it, but I think we need to have realistic view of what care coordination can accomplish. And we should also study it. There should be a theory of what care coordination can do and why it's doing it, and be able to systematically go about figuring out how to do it. I see a lot of people writing up elaborate care plans, and I'm not sure that anybody other than the person writing it up is reading it. And that worries me. What's the most judicious use of that care coordinator's time? How do you fulfill that expectation of speeding up the planning, enhancing execution, and lowering the total effort for a given solution? I think we need to train people who are inclined in this way to really think about leverage points of, in a complex problem of a child with medical complexity and all these components, what are the few things that we should tackle first? Because if we got that thing to change, we would unlock a number of other problems and make them much more tractable. Of being able to figure out how to do that, that's the art of medicine. I'd like to turn that into part of the science of medicine. We need to think about the art of thoughtful omission. Oh my God, do we need to think about this? Because the number of times that is the chief thing I have to do of saying we are not going to pay attention to all of the problems on the list. I'm aware of them, but we need to focus on the high leverage ones and let go of some things, and then do that in negotiation with the family just to be able to stay sane, focused, and increase execution of the plan. Try to do a million things. How many of you are stressed out because you have too many things on your to-do list? Okay? How many of you are coached over and over again? You've got to pick a few things and really get them done right. And yet that's not the message that we really give to families. Here's your laundry list of 15 medicines you have to take 17 times a day. We're also going to need to figure out how to, I think, do N-of-1 trials in a more expedient way, not to solve a statistical problem or meet statistical standards, but come up with what is the minimally sufficient N-of-1 trial to be able to figure out whether something is actually helping a child, and how often do we have to attempt to wean off a medicine to make sure that it's still necessary. This is another big one. We don't call this out, but typically children are being managed by ad hoc teams. It may be that quite commonly cardiology is working with pulmonary, is working with, but the people on the team differ. If I was told that I was going to have to go out and play pickup basketball, there was a skill I acquired during high school of how to get that team to work, people I may have never met, very quickly. And if you master that skill, you can actually go out and beat better teams. but again, it's not something that we're taught. As a physician, I was never taught how to potentially lead an ad hoc team. So I've got 10 kids in the panel. I'm likely to have 10 very different teams, even if they have the same problem. All the similarity would be that all these people have the same labels on them. The individuals would differ. I've already mentioned we may need to reduce the size of the team because it's harder to manage ad hoc large teams. But I don't know exactly what the right N is. And then we need to figure out, again, a theme coming up here of leading. A lot of the times, again, if something bubbles up as an ethics consult for a more medically complicated patient, I show up, who's in charge? And everybody does the, not me. And this is going to become an increasing problem, I fear, given a number of changes in healthcare and training, et cetera. We need to figure out how to help strengthen leadership training of people. And it doesn't need to be the docs, but somebody needs to be leading the team. That leadership is spelling out what the problem is, clarifying exactly what it is, clarifying those goals, confronting the trade-offs. I sat with a family last week where I had to confront some very serious trade-offs of a young girl who was dying of her cancer, about staying in the hospital versus going home. And one can do that, I believe, compassionately and clearly, but we need to be able to confront those trade-offs straight on as opposed to dancing around them, and thus people are left chronically unsure of what they're doing, why they're doing it, and you have to manage expectations clearly. And then this is the last point. Planning is worthless if you can't execute it. I often say decision-making is vastly overrated in healthcare. You have to not just make the decision, you have to execute the plan and sustain that. And the means to do that need to be developed better. What does it look like to have not just an ad hoc team that can make a decision, but then be able to execute that plan? This goes back to care coordination. How do you execute the plan? So, questions that you might want in a science of complexity to pursue. Theoretically, what do we want? Care coordination, medical home. What are any of these people being asked to do, and why should it work? And I think we have to become much more hard-nosed about why we think these things would work to improve outcomes, and what would be the precise mechanism so that in any measurement strategy we would be measuring exactly whether they did what they needed to do for it to work. But there are other issues beyond that. What does it mean that we all have different thought styles? Are there different ways that people should be involved in complex problem solving to accommodate the differences that we have in the styles? Are some people better at doing this than others, so they should be selectively brought in? Are there ways to train clinicians to be better at doing complex problem solving? Those are my thoughts. Thank you.
We'll go to the next speaker, Simon.
Good afternoon. I'm Simon Hambidge from Denver Health, University of Colorado. I'd like to thank Ed and the Lucille Packard Foundation for bringing this group together. I'm really looking forward to the next day. I wanted to share with you our experience just briefly with one system of risk stratification that's maybe a little bit different from some of the ones that you may have tried at your institutions, because we're a large integrated healthcare system, both adults and kids, and so we had to think about it just a little bit differently. Let's see. What I will say, in my new role I've been in for the last 14 months, I actually have to oversee the adults as well as the kids. So that's been a steep learning curve for me. This project was initially funded by a large CMS Innovations grant. So thank you to the folks in the room who were involved with that. However, anything I say is not reflective of CMS. And our institutional review board helpfully and appropriately determined this was not research, but quality assurance project. I just wanted to give you a brief introduction to Denver Health and Denver Community Health Services. Just talk about our risk stratification model. And an overview of the care models that we have then adapted to that risk stratification. and finally close with a brief word about sustainability. So Denver Health is a large, vertically integrated safety net healthcare system. It includes community health centers, which is what my focus will be on. But it also includes a large level 1 trauma center, level 1 for adults, level 2 for kids, 17 school-based health centers, and the Denver Public Health Department. So that gives us a lot of bandwidth and really embeds us in population health. Community health services is what I oversee now, and that's what I just wanted to focus on for a bit, because one thought I've had as we've been talking here is that this work needs to engage federally qualified health centers. 1 in 15 Americans is cared for in an FQHC. It's a much higher rate for kids, and it's a much higher rate for poor kids, between 1 in 5 and 1 in 10. So if we're actually going to talk as a country about taking care of these kids, it's imperative for us to engage our FQHC colleagues. So Denver Community Health is a network of 8 FQHCs, soon to be 9, 17 school-based health centers, urgent care clinic. We're approaching 500,000 visits and have last year had over 140,000 unique patients, and close to half of those were kids and adolescents. Almost all our patients are below 200% federal poverty level, and our institution serves over half the Medicaid patients in the city and county of Denver. We do a lot of resident training, and we do have robust integrated medical record and clinical registries, but we are switching to Epic in April, which will be a journey. Pediatric services. So we have a number of pediatric and family medicine clinics. We take care of 12,000 kids now in our school-based health centers. Pediatric specialty services on our main campus. Family crisis center. This is perhaps another when we're thinking about special populations. So we work with the city and county of Denver to do evaluations for kids suspected of abuse and neglect, and then that's closely linked with a foster care clinic. So we run about 80 or 90% of the kids in foster care through our system and create a health passport which will follow them wherever they go. And then we also have our hospital and urgent care and emergency services. So our goal, and you've seen a similar slide in an earlier talk, our goal over a 3-year period were to improve access, improve care, and lower cost. So it was an ambitious project. And this is just to give you an idea of our population when we embarked on this project. And for the 21st Century Care, for the CMS grant, we had 76,000 kids in the denominator. And you can see the age breakdown. I do want to point out at the bottom here, this is one of the important things about population health and risk stratification is who is your population, who are you talking about? So we actually have several populations. So our empaneled populations are those kids that we've seen in the past 18 months in one of our primary care sites. We also wanted to pay attention to non-empaneled high utilizers, so frequent flyers in either the ED or the hospital. And then also, we're a managed care company as well. We run a large Medicaid managed care program, and some of those patients don't get health care with us. They're recently assigned, and so we also felt that we had a responsibility for them, obviously. So just our approach, and I do want a couple thoughts about risk stratification. Especially, I think it's really important, there was a comment made earlier, this not be used to exclude services. Rather, I think this is what has been our experience. If you set this up right, you actually start identifying kids that you didn't know that had fallen through the cracks. And a lot of times, especially if they're poor parents, a lot of family chaos, they may not have the advocacy that the kids of parents in this room have. And so you can actually identify a lot of kids with an appropriate risk stratification tool that then you can start reaching out to. So we initially started using a tool that our state Medicaid office was using at the time. And quite frankly, This was, and it was interesting, this is where the adult peds things come in. So we had a pediatric and an adult group working on this grant, this project, and I was in charge of the pediatric part. And right away, when we started trying to stratify our kids using our state Medicaid tool, it didn't look like it was working at all. So we had some previous experience with the clinical risk groups from 3M, and I'd used it in a number of research projects quite a long time ago. And so we said, well, let's just see how this looks. And we started experimenting with it, and we ended up using it. And we felt the one challenge we were having, most of you I'm sure are familiar with CRGs, was that it's got these 9 strata based on different codes and utilization. And we felt that was not clinically actionable. So we wanted to translate that into 4 tiers, because we felt 4 tiers was, if you're stratifying your care coordination, once you've identified your population, 4 is a lot more actionable. So I spent a lot of time actually with our pediatrician who runs our special needs clinic, and one of our data analysts. We went through every single CRG and assigned it to a tier. We've since given that to Children's Hospital and are more than happy to share that. But we also felt that it was important not just to use the CRGs, but to clinically override with what we felt were some clinically very important factors. So we already had a registry for kids with special needs that we had set up back in 2008. And we knew that identified a lot of our medically complex kids. It was more of a medical complexity than a special needs registry, actually. And this was both ICD-9 and pharmaceutical based. So we said any kid on that registry is automatically going to be tier 4, no matter what the CRG says. We also threw in some mental health diagnoses into the tiering algorithm and said any kid with this diagnosis, no matter what the CRG said, is going to be at least a level 3. So they get a certain level of services. History of premature birth. The mother, in this case, would be targeted for an intervention to prevent another premature birth, or try to stretch out the inner pregnancy interval. And then high frequency utilization was the other thing that would kick you up into a higher tier. So this is kind of the key slide in our strategy. So this is our population health tiered delivery. On the left are the how the pyramid looks after we applied these CRGs and their overlaid rules to our population. And tier 1 are the healthy kids and adults. And in reality, this is 2 separate pyramids, one for adults and one for kids, right? And that was a key thing, obviously. You can't have, if you have just one pyramid, the kids get lost. So there's really 2 pyramids. We've got them lumped together here. Tier 1 is healthy kids. Tier 2 is typically kids with 1 or 2 chronic but stable conditions. Tier 3, you start to kick up the number of your conditions. And Tier 4 are the most both medically complex, but also some behavioral health, and increasingly want to incorporate social complexity into that. This is member per month, but just to give you an idea of numbers, Tier 1 for kids has about 50,000, and Tier 4 has about 500. So I think it meets your 1% rule for complexity. It's about 1% of the population. The other point you made that I want to address here is we were looking at both cost, medical, and family needs, but we set this up without looking at cost. We set it up, and then we looked at cost to validate it. And that's what's shown in the arrow. And this gave us a sense, yes, we might actually be able to make this sustainable we had set it up as a medical pyramid, but if there's to be cost avoidance, you can sustain it even after the grant money runs out. So you can see for peds, the Tier 1 kids cost about $76 per member per month, and the Tier 4 kids are up around $4,500, so a big range. The right-hand side of this slide then shows you basically the care models that were developed for each tier. And so this is an inverse pyramid, because as you go up in your complexity on the left, you need increased resources on the right to help the families that you're taking care of. So the lowest level, the healthy kids, they're best getting health information technology. They're getting text reminders for well child visits, immunizations, flu vaccines, and all of those improved, by the way. The second tier, you start, and integrated behavioral health, although it lists it here as only tier 2, 3, 4, integrated behavioral health is actually throughout, I should say. That was part of this program. Tier 2, you start to throw in patient navigators that are specifically trained to deal with the specific chronic diseases, and asthma is the key one here. Tier 3, start to throw in nurse care coordinators into the mix. And on the adult side of the equation, they started throwing in clinical pharmacists. We actually have not utilized the clinical a little bit in asthma, but not as much as we should have. I will say this includes, for instance, tier 3 asthma. You start to see home visits, for instance, with a nurse and a navigator, and that's linked up with Denver Housing Authority visits. So this is a small number of our sicker asthmatics. Let me just go back. So then tier 4, on both the adult and the pediatric side, multidisciplinary clinics for kids with the highest medical complexity. And this is, I'll go a little bit more into this model. This is a familiar model to all of you. This is just another look at the different services that are provided for each of the tiers, from panel management to care management to complex case management to high-intensity treatment teams as you go up the pyramids. So we really redesigned our care teams. We feel that we have redesigned the way we practice pediatrics in our healthcare system and adult medicine as well. So we've added patient navigators, we've integrated behavioral health clinicians, we've added nurse care coordinators, and then we've created these high-intensity teams. And just to give you an idea of who's on the team, and I should say we've had family involvement with this program from the beginning, from even years before we got the grant, and through two main avenues. One has been through Colorado Family Voices, and they've been very involved, and we actually hired, if you look on our staffing list here, the family navigator who's in the, let's see, the navigator is a family navigator. We actually contract with Family Voices for a full-time family navigator who's now based in the medical clinic and works in the community. And that's been a huge, she's been wonderful. Families love her, the staff love her. The other thing is that a number of the staff of this clinic are parents of kids with medical complexity. So, for instance, the lead nurse care coordinator has a teenage son with all kinds of medical issues. So that's been our approach, is both staff and then Family Voices involvement. This is supposed to be a 10-minute talk, so I'm not going to go into what I think are the most important outcomes. The qualitative outcomes with the families and staff, both of which I have a lot of really wonderful quotes, and I actually, in a longer version of this, I have some of those quotes, but just very meaningful stories from families and from the staff. The engagement of the staff in this clinic has been really amazing. I mentioned some of the quality outcomes, so we have seen improvement in well child visits, immunization rates, asthma compliance. But what I want to talk about briefly is sustainability, because a system like this is expensive. It's got significant IT expense, and it's got significant personnel expense. In a system like ours, we can, so just to give you an idea, Denver Health, this costs us about $2.5 million a year to sustain. So we have to be able to justify that to our hospital budget committee, which is not known for their largesse. We have to be able to show them some cost avoidance. And because we have one foot in the fee-for-service world and one foot in the accountable care world, we can try and do that. So some very preliminary results, from the first 11 months of the program. And these were shipped out to an independent actuary. These are not our analyses. So we took all our data, financial, utilization, shipped it out to Milliman. And they came back and they said, we think you saved $7 million. And most of that was in adult tier 4. But a significant enough portion of that was in the Tier 4 pediatric population that it more than covered the cost of the pediatric part of the team. And so based on these preliminary data, our budget committee actually wrapped this into our ongoing budget. So this is now part of our healthcare system. There are, this is iterative, this is ongoing. I feel like we actually do a pretty good job at Tier 1 and a pretty good job at Tier 4. Tier 2 and 3, in my mind, are still have a lot of work to do. And this is a never-ending journey. So in our next version 4 of our tiering algorithm, the main things we'd like to do are get more robust about our behavioral health integration into this model. I feel like we've only got a partial accounting. And we know that a lot of medical utilization and cost is driven by behavioral health. And especially, and this will lead into to Rita's talk next, social determinants of health. And because we're a public health department, because we have ties around to the schools, I feel like if we can actually start to address some of these directly once we identify them and account for them in our tiering scheme. So that's one of our goals for the next round of tiering. And this really is a continuous process improvement. And I just wanted to close. There have been a lot of people involved with this project. Tracy Johnson actually wrote the grant and has been leading us on this journey, and then a lot of other people who've contributed heavily. So, thank you.
Now we'll turn it over to Rita.
Good afternoon, and I'm a consummate rule follower, so I will not go over 10 minutes, I hope. So I'm here today, thankfully, because Ed gave me the opportunity to do this. I'm going to share with you some of the work that we've been doing in the Center of Excellence on Quality of Care Measures for Children with Complex Needs. That's what that ugly acronym, but very beautiful logo stands for. This is one of the 7 centers of excellence that was funded on under the 2009 CHIPRA mandate to have a pediatric quality measures program, and it's funded through a cooperative agreement between CMS and HRQ. So I'm going to be talking to you a bit about work that our group has been doing, really looking at social complexity in the context of medical complexity, and really asking the question, how should it be factored into risk assessment and tiered care? So why do we need to assess risk and have tiered care? Kind of an important question, right? Well, as you all heard, and you all know, I'm not telling you anything you don't know, there's a current focus on cost containment. We're all being asked to give high-value care, right? So we're supposed to increase quality and at the same time reduce costs to make value increase. But what if high quality actually costs more? And I ask that not just pragmatically, but practically, because we did a randomized controlled trial at Seattle Children's. We included kids in that trial who were kind of Simon's Tier 4 and Tier 3 kids. We said, if you're randomized to the intervention, you get our comprehensive case management service, and if you're not, then you get usual messy, fragmented care, okay? And what we found over a 2-year study in that randomized controlled trial was that all of our quality metrics got better. Families had better access to mental health services. They were getting the home care they needed. They were getting their durable medical equipment. And guess what? It costs way more than the control group. So that was a depressing finding, and I'm just going to leave it at that. It's expensive to give high quality care. It's expensive, like what Simon was saying, to do these kinds of interventions. And I think if you limit it to that top 1%, maybe it can be cost savings. But if you want to be a little bit more inclusive and get down into Tier 3, it's going to start getting prohibitively expensive. So if we have limited resources to address the problems faced by children with complex needs, how should those resources be allocated? That's what we're struggling with here, right? Do we base it on the numbers and types of diagnoses they have, like we do with CRGs or with the pediatric medical complexity algorithm? Do we base it on being the super high utilizers? What about the social context in which you live? Maybe that should be part of what we're basing this on. And there's probably something else we should be basing it on that none of us have even thought about yet. So I'm going to stop for a minute and say, what is social complexity? Because that's really an important thing to start out with. In our center, we decided we would approach this by doing a comprehensive literature review where we looked at different social risk factors, both socio-demographic factors and adverse childhood experiences, and really try to determine which of them seem to have the most impact on child health and health care. And so one potential definition is the one that our center landed on. We did that literature review, had a lot of iterative, lively discussion at our center meetings, and this is the definition we landed on. A set of co-occurring individual, family, or community characteristics that can have a direct impact on health outcomes or an indirect impact by affecting a child's access to care and or a family's ability to engage in recommended medical and mental health treatments. So what do we know about the impact of social complexity as I've just defined it? If you have social characteristics like poverty or limited English proficiency, you'll find they're associated with decreased access to and use of primary care. You're much less likely to have a patient-centered medical home, which leads to increased use of places like the emergency department for care that you hopefully would be getting in a patient-centered medical home, and hospitalizations for uncontrolled conditions like asthma. You have increased reports of unmet needs related to getting help with managing a child's medical problems. We know this from the work that Christy Bethel just recently published. So thinking about this, one of the things our center was asked to do was to come up with a way to stratify kids by medical complexity, which we did. We developed the pediatric medical complexity algorithm. But Jeff Schiff, who's sitting in the audience, said, yeah, but what about the social risk factors? We're not getting at those social risk factors. What if a kid ends up in your non-complex chronic group, but their parent has a mental health problem? Don't they qualify for care coordination? Don't you think they're going to need it just as much as those kids that your algorithm is capturing at the top? And we all said, yeah, he's probably right. So we need to think about this more. So we were very fortunate in our center to be partnered with Washington State Medicaid. They have this, the Washington Department of Social and Human Services has this amazing integrated client database where you can link a biological child-parent dyad and get information from all different kinds of state agencies, not just Medicaid claims data. So we had access to this very rich database of different social complexity risk factors, which allowed us to do an interesting study, which I'm going to tell you just briefly about. So we looked at the 2012 population of children enrolled in Washington State Medicaid, and we broke the kids into those less than 5 and those 5 to 17 years old. And not surprisingly, when we applied the pediatric medical complexity algorithm, we found that the great majority of children fell into the healthy group, so no chronic conditions, about 80 to 85%. If you sum all the chronic kids together, they're right around that number that we all talk about, 16 to 20-ish% nationally. And the complex kids within the chronic group make up about 5%. But what about social complexity? So we applied that great database they had to the same population of kids, and here were the factors we were able to look at. We were able to look at parent, family, and child risk factors. And I want you to notice it's the same kids, but how many more of them have social risk factors than who we would have picked up if we just looked at medical complexity, okay? Upwards of 40% with parents who had some involvement with the criminal justice system. Over a third who are living in severe poverty or who have limited English proficiency. Okay, so then we wanted to know, so many kids have a social risk factor. How many of them have more than one? Well, we found that only 20% of kids had no social risk factors. We found that another about third of the kids had one, And the remaining 50% had 2 or more of those risk factors I just showed you. Okay. So we, as a proxy for access to care, we decided, all right, so if you had one of these risk factors in 2012, how often did you use the ED in 2013 as a proxy for access to primary care? And what we found was that for nine out of the 11 social complexity risk factors we looked at, the odds of having an emergency department visit were increased if you had that risk factor. Particularly influential was poverty, and for children having a mental health service need, a substance use problem, or having involvement with the criminal justice system. Now, if we look at numbers of those risk factors, we were interested, was there a dose-response association? So if we see more risk factors for a child, does that increase their risk of ED visits even more? And in fact, we saw a pretty much linear relationship there, whereas the number of risk factors a child had increased, their odds of having an ED visit the following year also increased. So what did we conclude from this work? Several social complexity risk factors are associated with suboptimal access to health services and poor health outcomes. They're poverty, limited English proficiency, a parent with a mental health problem, a parent with criminal justice involvement, child welfare system involvement, homelessness, child mental health service problems, child substance abuse, and child juvenile or criminal justice system involvement. So as we think about tiered care, I really ask us to keep in mind, even children with a single social complexity risk factor are at risk for worse outcomes. And given limited resources, we need to really focus on children with multiple social complexity risk factors, just like we need to focus on children with medical complexity. If we have a child with a non-complex medical problem, we need to take into account if that child is also faced with social complexity. And I'm going to just say we have to do all of the above and probably more. What can we do about social complexity? That's a tough question. Care coordination can help with access to care and services for children and their caregivers. It can improve communication between families and providers and between different providers. But here's some things I don't think it can do. It can't prevent homelessness. It can't address poverty, and it can't reduce adverse childhood experiences. We really need different solutions. We really need to start thinking out of the box and pushing ourselves in how we think about what are the solutions to these problems. The medical system can't do it all. I'd like to recognize the incredible number of people who took part in doing this work, and it's exciting to me that 4 of them are in the audience today, so it's great. Thank you.
So I will briefly reflect on some of the key points heard, and I will make it brief because I see people already lining up. Probably have much wiser thoughts than me here. I thought I'd have to take some time. But quickly from Chris, I think leading with a patient example, which was just a wonderful way to start the session, talking about the science of complexity, including classification tools, really the theory of change, touched on issues of training, defining problems and success, interprofessional teams and high-performing teams, and both how do we foster that and the science behind that work, asking too much of care coordination and measuring the effectiveness of care coordination and the science behind that, how to lead ad hoc teams. I love the pickup basketball example. I used to be much better at pickup basketball than I am today, I have to tell you. And accountability and execution. From Simon, hearing from the work at Denver Health with both adults and kids, and really, having been there, I think some amazing work that they're doing. Risk stratification and tailoring it to kids. Love the examples of software plus the clinical overlay, validating the theory of change with the sort of 1% rule we heard about, tailoring care model to the risk pyramid and care teams, your results and cost avoidance, and ending with the sustainability point. And then from Rita, this issue of, I love, which you're going to, as a payer, it's going to be interesting I say this, but the issue of high quality care can cost more. That is true, and I think it's something we don't totally recognize as well as we could in the value equation, so love that you highlighted that. Social factors impact on complexity, the dose response of social risk factors to ED visits, and then lastly, and I think poignantly, hitting on how we consider how social and medical factors are combined as we think about tiering and how to combine those. So just one more point before we open up to questions, and I promise we will end on time or early, because we were between you and a reception, which is never a good place to be between. Just one more round of applause for the great panel. All right, so I will moderate. Please keep what Susan Dentzer always say, don't have your long comments masquerade as a question. But I know we have real experts in the room, so look forward to the questions and discussion, and we'll just go back and forth.
We'll do this really quickly. Rich Antonelli from Boston. So we did a study, and I think Dr. Berry was gracious enough to cite it in the paper that prepped for today. There's no single driver of care coordination utilization that bumps up the need for those services than having this social complexity. Even kids that were technology dependent were relatively flat with utilization. You superimpose an ACE or something like that, and boom, they're more expensive than a tech dependent kid. So I was trying to figure out, because I couldn't speak to the first one, but I'm going to bring up EPSDT. If we, right now, built into EPSDT, if there was an explicit expectation of care coordination, an assessment of needs and strengths of assets of the family, and what needs to happen moving forward. So this is less of a question, I think, except as a challenge. If we embrace that care coordination is important, isn't it time to impose a set of measurable activities that actually align with these types of outcomes? So I think, that this is really, really, really important stuff. The CRGs, Simon, I think it was elegant and brilliant that you took 9 and brought it down to 4 so we could think about some actionability. We're doing that in our models as well. Smaller models allow us to move toward that. But the problem with CRGs is it's claims-based, right? So until I can submit claims for non-face-to-face encounters for addressing homelessness or maternal depression, it's going to be really problematic. So it's just a plea to measure what matters. Thank you for a really wonderful set of presentations.
Thanks a lot.
Can I just make a Yeah, sure. I think once you have... Oh, there we go. Once you have the tiers set up, you can populate them. I mean, then the CRGs don't become the only thing that feeds into them. So you can populate them with anything you think is important, which clearly needs to happen. Yeah.
Hi, Lee Sanders from Stanford University. We're a tour de force, guys. Thank you so much for everything you just provided. I wanted to ask you about 2 themes I didn't hear you talk about around risk stratification. One is temporality, and the other is context. So temporality, we have children who are acutely high risk and those who are persistently high risk. And how are you approaching that? And then in terms of context, taking care of a complex kid socially or medically in Miami was very different for me than in East Palo Alto and very different than the Central Valley of California. And thinking about how we can further elaborate on some of the models you guys have developed to assess the match between complexity of a family and the capacity of the services that are accessible to them, geographically accessible, so that we can really help drive systems change. So your thoughts on those 2 themes?
So in terms, I think your comment about context is huge and very important for us moving forward to really know that within, even at the state level, right, we probably have 50 different contexts within which we're working, and to really understand on a population level what are the key issues for your population, because then that starts to inform what do we need to be screening for, what services do we really need to put our resources into, because which pieces of that social complexity puzzle are really driving poor outcomes in my state. So that's, I think we all have that upfront groundwork to do. We also have tremendous upfront groundwork to build the data systems to do what they are able to do in Washington. I'm just lucky I live there because I couldn't have done that study in most other states, right? So, but it's the cool thing is it's doable. They did it, right? You know, and that's an important message. And then I think the temporality comment is also really important. It tells us that you can't just risk stratify once. You have to be doing it on a regular basis. And, you know, I know my colleagues in Cincinnati are actively doing that using PMCA. Basically, every time a kid, they're amazing. They've like taken the tool and done so much more with it than we have. They've put it into their EPIC system, and every time a kid comes in for a visit, their PMCA category shows up on the screen, and they're refreshing it monthly because the kids do move in and out of the different strata pretty frequently.
Yeah, if I could add to that as well, they move out with incredible frequency, actually, and the adults even more so. We just published our adult data a couple months ago in Health Affairs, and hopefully the peds data will be coming out soon. But so you have to have temporality built in. For instance, as you know, a kid with significant prematurity coming out of the NICU is going to be probably a Tier 4 kid for a little while. But by the age of 2, a lot of those kids are Tier 1 or Tier 2. And so you have to use the temporality. I think for the regionality, that's an excellent point. And honestly, I think looking to our family voices, partners, to help us, because they know their neighborhoods better than anyone, and they can help us understand the different regional context.
Great, thank you. Reed Sulik from Minnesota, one of the child psychiatrists in the room, also kind of trained as a pediatrician as well, so this is really kind of a great time to be here. Thanks to all of you. I mean, that was just an extraordinary panel presentation. I want to reframe an idea that I had while listening to each of you, and it had to do with cost. And one of you mentioned Milliman, that you're having doing an analysis. You know, when we looked at the Milliman reports recently over the last year when they came out with the adult data, now they haven't published the pediatric data, but we've been looking at what is the cost, the total cost of care impact on a patient with a medical condition if they have a co-occurring behavioral health condition. The thing that I'm not hearing discussed about the Milliman reports and other references to cost data like this is when we look at claims data that requires that there is already known a behavioral health diagnosis. The behavioral health diagnosis is actually being treated. Two things that we know we're really horrible at in our systems. We're really horrible at identifying the behavioral health condition and the behavioral health, and then getting access to the appropriate evidence-based and effective treatment. Rita, your discussion of social complexity really opened my eyes, because I've been using the word behavioral health need to describe what you've been describing as social complexities, trying to broaden our thinking about our potential impact of cost. You know, if we do this right, we can impact cost greatly, so that what appears to be higher cost or higher quality care today has dramatic outcomes on reducing total cost and total burden of suffering on the child and the family and even the community. I think that there's a way, and I just want to float this out there for you guys to comment on, but I think there's a way to reframe how we think about cost when we think about broadening our definition of need and thinking about the behavioral health needs of each of the individuals that fall into these categories. And maybe that if we address those behavioral health needs aggressively in a very systematic way, we can monitor how quickly we can move somebody from the higher tiers to the lower tiers. So just float that out for comments.
I mean, the ideal state is the British Health Service, right, that we heard about earlier, because they're really thinking about everything and incorporating a life trajectory. How we get there but it's this two-generational approach that was mentioned earlier. It's thinking about the whole child and the whole family, and you're right. Certainly in my presentation, I didn't have all of that global approach. I think that's where we want to go.
Hi, Danny Armstrong, University of Miami. I wanted to start with just a comment about our first speaker. We've talked a lot about social determinants of health, let's don't forget about social outcomes of health. The impact of a complex disease on not only the child who's being managed, but on the finances of the family, their ability to make choices between food versus medication, the impact on siblings, cousins, grandparents, and others. And I think we sort of lose track sometimes in putting the social determinants at the front end, but they are often the outcomes of our management, and that's a cost that's unaccounted. Within that framework, what I really wanted to kind of throw out, the first phenomenal presentations, but some questions about where we're going with the science and with prevention. We're focusing really a lot in this meeting and in a lot of our work on health services research and finding out what works best. But in my other part of the world, I deal a lot of work with folks who are talking about precision medicine. And one of the issues that precision medicine is coming up with was, how do we target cancer and cure it more specifically and reduce the toxicity? But there's an issue related to health, to the social determinants that we may be sort of losing track of. Precision medicine may offer us the opportunity to provide precise, effective treatments in a shorter duration of time with better adherence than we've ever been able to do using our large group strategies in health service delivery. And so I propose that one of our conversations and our thoughts about where we're moving forward is how we take advantage of this explosion of research and how we assure that our changes in health service delivery continue to support the advances in healthcare so that 20 years from now we're not doing what we're doing today. A really important piece of the conversation that gets lost. But the other part of it is we look at these various models to control cost. Where does prevention fit in? How do we in health systems, in children's hospitals and children's health systems, engage the public schools, the child care centers? Obesity in 3-year-olds is pretty high. Obesity is related to so many conditions. American Cancer Society now says 30% of cancer is associated with overweight nutritional issues. And so we've got an opportunity from a prevention perspective, not just providing access for acute care or chronic care, but to really think about how we link that to prevention. So I wanted to kind of put that out to see where your thinking was on that question.
So I couldn't agree with you more. I think prevention is certainly at the heart of what we do in pediatrics. It's, as you saw, 85% of what we do, right? Because cost is such a driver, it always gets left behind, and it could potentially prevent a lot of those future costs if we would pay more attention to it. In terms of the science, my hope is that we heard earlier about the importance of connectivity between healthcare systems and other systems, and really thinking hard about how can we begin to do studies that aggregate data from those two systems and really understand the whole picture, because we're getting such a small slice of it if all we're looking at are health services. So that's a really difficult problem, and I hope that in my research career that we're able to link some of those data systems to do that work, because I think it's really important.
When we talk about prevention, we also can think of it in tiers of primary, secondary, tertiary. Admittedly, I would love to have primary prevention for all the children who are born with congenital defects and genetic disorders. In many ways, that's a dream that can't be applied. Maybe if there's a fantasy that someday we're going to be able to do in utero gene transfer stuff. I will also say that the Human Genome Project was supposed to deliver on the promise of precision medicine 20 years ago. It just seems like we keep pushing that forward. A comment that probably people would object to, but I'll say it anyway. I think there's going to be some disorders that are exquisitely going to be improved by precision medicine, and much that will not be touched. I will say that most of the dilemmas that we face in secondary and tertiary prevention are really what I think we're talking about here. The cat is out of the bag. There's already a problem. What do we do to constrain it, to do harm reduction, to basically focus on, we have in palliative care a whole sibling program to try to take care of the siblings of the children who are dying. So I agree with that comment entirely, of the collateral impact of having a high-end special needs kid. But it's really going to be a rehab mentality of secondary and tertiary, particularly prevention, so that the harms don't continue to expand once you have the first problem, that they don't cascade into a whole world of other problems.
Just one other quick comment. Something I learned from David Bergman a few years ago is we may need to think about how we deliver preventive care to our healthy kids, because we actually get reimbursed as pediatricians in the U.S. a lot of money, and if we could take even a portion of that money to use for the things we're talking about in this room, by delivering more e-health services for those kids, for instance, then perhaps that's one way we could help fund this.
That's great.
Jim Perrin, Mass General Hospital and American Academy of Pediatrics. Just as a quick aside, we've been fighting with NIH to get precision medicine initiative to include kids cohorts. So far we've won, but we need everyone's advocacy there. But this is mainly for Chris, but the rest of you too. 30 years ago, a group of us published a paper on severity of illness, how do you measure it, and asked sort of the same questions. I'm so pleased to see that we've made no progress. But I really thought your paper was incredibly thoughtful and raised such a rich panorama of issues. And I'm trying to figure out how to make use of it. And one question I guess I have for you, and maybe for Rita as well, in the context is, so how do other frameworks help us use some degree of thinking about complexity? I mean, is the International Classification of Functioning, as one example, a strategy to look more broadly at the interaction of ability and disability with community and so forth, helpful as you think about complexity?
Well, Jim, I mean, I think we are much better than we were 30 years ago, in part because of your legacy, and we have a room full of people who are focused on it. And we have behind this many more people, Ed was telling me, who want to come. The time is ripe for thinking, I think, more systematically and rigorously about either who are the patients that we want to take care of, that's the job of classification. What I was really trying to point out is where I don't think we've made great progress is what do we do once we have defined them. So you get the job, you hand them to me, and I have to take care of whoever you do. So there's a classification person. I think we have a lot of opportunity to look carefully at what we are doing in clinical practice and both define the engineering task, what are the components, how do they work together, and think about systems re-engineering in the micro setting of what's going on for a given patient or a given group of patients in a clinic, and then scale up to think, okay, what does the macro system need to do to support that? But I'll keep coming back to the bedside. We were talking earlier, I think one of the biggest issues we have is the emotional management of coping and adapting over time and how that actually affects people's ability to continue to do task performance at high levels, including the providers who often are treating their own anxiety with some of the therapy that they provide to these higher end kids. So that's where I think the sweet spot is. What I'd like to see in 10 years is that there is a whole field of complexity management that has a much more rigorous science behind it than what we have to date, both for the micro and the macro level, as well as this classification. Who can benefit the most from that? How do we think about the social determinants of health, these social risk factors as to who should get brought in? And then once they're there, what are the interventions we're even going to do? I'm a big believer in co-located, integrated behavioral health, right, side by side with physical health. How will we go about doing that? How do we know that that actually is cost efficient? I think there's a lot of questions, and I'm excited about what the next 10 years will bring.
I don't have anything to add to that.
David.
So thanks for that. And it really was wonderful. And I love, Chris, the fact that you raised the point that whenever we talk about risk stratification, we have to think risk of what. It's something I've annoyed people by saying in way too many meetings. The interesting thing to me is that it whenever someone starts trying to stratify risk of cost, risk of needing to use my time more. I mean, as a practitioner, I think, what's the risk that this patient is going to need a 1-hour appointment instead of a 20-minute appointment? That's actually what I stratify by. So, you know, whenever we start doing that kind of risk in medically complex kids and families, we always come to the same things that you guys have found, that behavioral health matters, that it matters to think about social complexity. And I guess I'm wondering about the implications of that. There's a project in Colorado going on called the Colorado Opportunity Project, where they've actually pulled together the Department of Social Services, the Public Health Department, and Medicaid to think creatively about what sorts of supports you need over the life course to create the maximum number of tax-paying citizens by age 40. I mean, it's not a bad outcome to shoot for. And wondering whether we can braid funds from different funding streams to support that sort of thing. Is that where you're going? I mean, is that where we're going with this as you think through how the social determinants and behavioral health things factor into what might be called the pure medical components of this risk?
I think it's absolutely where we need to be going. I'm not sure it is exactly where we're going, but I think it is where we need to be going. And if we can't find ways to, I mean, to me, David, that's not a bad outcome, right? If you can take the population of children today and say that they're all at the age of 40 going to be, you know, contributing tax-paying citizens, that's not a bad outcome, right? That means they were ready for kindergarten, they graduated from high school, they probably went to college, you know, or at least for some of their life. So that's the other thing I would push us to think about are, you know, we're so fixated on, you know, cost, length of stay, readmissions, ED, return visits. I would love for us to really start getting a little bit better about thinking about what outcomes really matter and how do we really start to rigorously measure how we're doing on those outcomes and how do all these things we're doing that we think are making things better influencing those outcomes, because that's what really matters. It's not how long the kid ends up being in the hospital.
From your mouth to the deputy administrator of CMS's ears. Oh, wait.
David, I'll go ahead.
I've been waiting to say that line.
A couple, and then I'll be brief. Yeah, I think those are the key issues. I'll reflect on two issues. I think one, this outcomes, measuring the outcomes that matter at a national, state, community, et cetera level. Thinking about how we measure those and how we drive improvements. Two, on the BRAID funding, I know you know this, but you know, we think critically important. We're trying to push through state innovation, including in Colorado, through accountable health communities, which we've said we're working on and will announce soon, and a number of other initiatives to really try to push on this issue. So I don't think we have it right yet, and we probably will continue to learn for some period of time, but how do you really accelerate that pace of change?
Hi, I'm Jeff Schiff from Minnesota. Just a couple things. One thing I had to say about payment, when I started in Medicaid, I'm the medical director, I would say publicly, if we had something that cost $100,000 but would cure folks, we would have to find a way to pay for it because we're an entitlement program, and that's what we did. And then hepatitis C came along, and we had something that cost $100,000, and we had to figure out a way to pay for it. And we negotiated, and it's now a bunch less, but I feel like we as pediatricians should be a little less, I would say, apologetic about what our patients need in order to get the coordination they need to be well. And if it's really good care coordination, then we should go out there and claim that as what they need rather than sit there and figure out how we're going to eke it together. The next thing I just wanted to say real quickly is I'm a little jealous of the data that Washington State has, but we're not far behind in Minnesota. And we issued a report like Rita's, and we put it out there. And it's, I would say, slowly or rapidly, depending on your perspective, changing the conversation in Minnesota around how social determinants affect healthcare, because healthcare is so expensive, and healthcare is an expensive way of taking care of social needs. You know, so I think so I encourage other states to follow that model and to put that data out there for their leadership, because it's hard not to react to data. like that. The last thing I want to say, which is really my question, is, Chris, I appreciate you talking about the boot camp for not well performing care teams. But I think that that really gets to me is we need to measure, and we just were at NQF, and Rita, we had some measures that were approved through the Rita Center. We need to measure the quality of care coordination at a deep infrastructure kind of level. And we need to measure outcomes that we all think are valuable. And I think one of the points that maybe we could take away from this, and I'm just curious about your reaction, is we need to maybe measure less processes that don't matter, that are in between.
So is care coordination a process or an outcome?
Care coordination is a infrastructure as opposed to a process like how many well visits people have.
But I think this is the kind of arguments or debates we could have if we had a clearer sense of care coordination as a means to an end. And as a means, it's a process measure for me, where the end would have to be some of a variety of outcomes. That could be in the family, that could be specifically for the child. And we could debate, does it really matter to measure the process? I often think process measures are very helpful because you can see if an intervention fails or succeeds. We just never did the process. That's why it didn't work.
So if I could just say something, I think we talk about infrastructure, process, and outcomes all in the healthcare system, but we don't talk about deep infrastructure, which was what you were talking about, like did the infrastructure actually work? And we don't talk about outcomes like are people healthier and what's their well-being and their families.
All right, let's keep this up for 2 more exchanges and we'll have a deeper conversation than we might otherwise, because that deep infrastructure starts to look like the structure doesn't do anything. It's not magic. It's not action at a distance. It does something by doing something, i.e. it follows through in a process. So even when we talk about the macro structure of Medicaid or Medicare, it doesn't do anything until it starts to pay people, starts to issue regulation. Those regulations have to be read. And all of those would be process measures. So when we think about how the rubber hits the road in a mechanistic way, what I would be pleading is let's get clear about which of those steps in the deeper sense of, to what degree did we do a face-to-face? How much was the care plan written up? Did somebody actually read the care plan who wasn't actually at the meeting? Did they skim it? Did they actually? All of that would be, for me, fascinating process measures to, did the child get readmitted? Did they get all of the care in a non-redundant way? Were the things that were being done in a duplicative manner? Was it highly efficient? All of that, I think, are things that we could tidy up. Like I've even listening to the conversation we've had when we talk about local area resources, to me, those are resources for problem solving. And I didn't ask, when Lee asked, his question, what's different about Miami versus Palo Alto? Is it the resources or is it the population of kids are different? Because if it's the children are different, we're not surprised that the problems that they have are different. But if it's the same kid in 2 different places, to me, it's that the problem changes because the solutions you have available to you have changed. So again, I think if we work to try to come up with a common way to talk about and then probe these issues, because I agree with you, it'd be very interesting to see how care coordinators do their job differently. When we did work, Jay Barry and I tried to figure out what are care coordinators or discharge planners actually doing. They all have a different algorithm. And yet, you just need a discharge coordinator. We're going to be able to figure out what in the secret sauce is really the key ingredient until we understand that secret sauce down in detail. Yeah.
So we have 4 questions left in 6 minutes. So we may or may not get through all, but the only way we will is if it's quick questions.
I will make it quick. And this is David Bergman from Stanford Children's Health. Just want to build on what Jeff said about jealousy. I have real data envy of Rita and what you got in Washington State. When I think about doing it in California, I get a giant headache. But what I wanted to ask, one thing we can get is zip code and census tract. And I put the question to all of you, is there any role for geomapping as a shortcut to get to social determinants?
Yes.
Yes.
And no. And no. Because there are families that live in those zip codes who do not run into problems. We need to study both the positive deviants as well as the people who are struggling. So the problem with a zip code based, and I've done plenty of it, so I'll confess to the sin, is that you are group classifying individuals who are going to have variation in outcome even at that group of just exposure, and it's relatively imprecise. Let's leave it that way. It's better than nothing. But be careful of that because it tips us to think we're looking for deficiencies. What I'm intrigued by are the people who have all of the problems that Rita mentioned and wind up having a very different experience. We need to talk about a deep process measure. What are they doing that enables them to survive and thrive despite the adversities? And all of positive psychology, I think we need to think not just of the negative aspects of deficiencies, but the positive aspects of coping, adapting, and then remediate the injustice of the situation. That's
I think
a
they have
separate issue.
they have a family navigator. I'll bet you anything. When things go well.
Let's find out. Because
Yeah,
I've
no,
known
we should
families-
study it. You're right.
I've known
But I
families
think-
that the family navigator is called, Rita, and it's the mom. Or, and I will say one thing, I watch a lot of dads who work mightily, and I think we have to be very careful. If they abandon the family, that's a different issue. We are seeing more men who are the primary caregiver as the wife is the one who can remain employed, or they're holding down the 2.5 jobs and are going crazy. And I want to soften up our approach to the men out there because as we are seeing increasingly, they're the ones who are at greater psychosocial risk for a whole slew of things in midlife and beyond.
There's also some innate resistance. And, it's the dandelion and orchid hypothesis, which is a beautiful hypothesis.
Positive and negative deviance. If you want to read a book, The Other Westmore. Next question.
I'm Cynthia Boyd, and I'm from Johns Hopkins, and I'm a geriatrician. So great talks in the interest of being brief. So I never see someone with 12 problems where you can treat all 12 problems independently. I'm curious how often that actually happens in pediatrics. I suspect it's rare. And also thinking about those care plans that are not always read. My question is my experience is that EHRs still drive us towards care that is treating all of those issues as very independent, even when that's not what the providers are actually trying to do. So my question, which I think is really a challenge for any model of care for these patients, is how do we make EHRs work to support the thoughtful approach to care that you describe, where there may be deliberate omissions or you've weighed complex trade-offs and those need to be reevaluated in the future. So how do we harness the potential that's always talked about them? I think harness might be the wrong word, at least for the systems I've used. It might be more reboot.
Get unshackled from? I mean, if you think about rounds, what do we train residents to do? Is to run a problem list. And they talk about the first problem. Are we done with the first problem? Move on to the second problem. I usually have to stop them there because the third problem that they want to talk about is actually affecting the first problem. We inculcate a component model of independence on the problem list. So I agree with you. If you got 12 independent problems, that's quite an accomplishment. Almost always they're related.
Right.
But we do not train people to think about how to do that. So in our hospital, we keep oscillating back and forth between a system-based approach, a problem-based approach. Either one is going to run into this problem of connectivity across different levels of the problem. And we don't talk about that. Makes it hard to figure out my style of handling the connectivity would be different than 4 other excellent pediatricians. So the residents get confused, so we keep backing away from it. But I think we have to figure out how to break through that sort of human thought structure sound barrier to figure out, okay, how are we going to have an honest conversation about how we handle these connections to do problem solving?
So I'm Alan Glasseroff, and I guess I'm one of 2 adult physicians in the room. Cynthia, thank you. I'm at Stanford, and I run a complex program, and you'll hear about it tomorrow. But what we often take care of are the adult survivors of childhood, essentially, and with trauma being the story that really drives a lot of the chronic illnesses. If you look at the issue, and I sympathize with Seattle Children's and Rita's presentation about we didn't show that we save money, what you're looking at is there are groups of people who cost a lot of money, and what you discovered is that if you add in the social determinant issues that you did a really good job delineating, that's where the delta is in the cost between what you can save and what you can't. And my question is around that, how good were your interventions in that world? Because you had implied that you said that, a care coordination team can't do it, and I utterly agree with that. And I also agree with, the whole concept of positive and negative deviance. If you look at the really together parents taking care of very complex kids with cystic fibrosis, other conditions, they are amazing what they pull off. And then there are other people whose parents are in jail or drug addicted, and even if they don't have those complex conditions, they are at high risk later on in their life. So I think it's really about, if ROI is what we're all held accountable, and the only pot of money is healthcare, and we don't get the other pots of money, what we need is the discipline to use Venn diagrams where there's complexity medically, and there's also social complexity, and we have an intervention that actually makes a difference. So.
Yeah, and I don't think we were successful for exactly the reason you just pointed out. The intervention couldn't address all of the social complexity risk factors that were identified.
If I could just add from the adult experience at Denver Health, the Tier 4 adult clinic is actually what was driving most of our cost avoidance, but more importantly, it was doing the right thing for those patients and keeping them out of the hospital, and that was how it was saving money. And a lot of what they were doing, so a lot of substance abuse treatment, a lot of connecting with community resources and homes. We haven't gone as far as some health systems, although we're actually talking about it, which is actually buying long-term residential facilities for some of these adults. I mean, there are definitely places around the country that have done that. And so I think actually those clinics can address some of the social determinants. You just have to think creatively.
So
Very brief. Very brief.
Okay.
Matt Sadoff, I'm a pediatrician and a complex care doc these days. Just building on what Chris said and what Rita said, what your approach of what we're seeing a lot of is when complicated children meet a complicated system. And Rita's reductionist approach to really identify what the real factors are. I think something that's not being mentioned is the complicated process that people need to go through to get the services that they need. DME, getting a hospital bed can take almost a year sometimes with multiple denials. This adds an incredible amount of stress to families, to provider teams, and I think this needs to be really looked at in a way, again, to take a reductionist approach to developing a less complicated team, a less complicated care map for each of these families. And it's wonderful presentations all. Thank you.
Great comment. I want to thank everybody for their comments and for the excellent panel. Thanks for that.